distant metastasis has occurred. Okay? And there are test questions about the TNM classification system, so you want to know about it. Laboratory and diagnostic testing for cancer. I've given you kind of a breakdown here of the different ones. That I do want to talk about are tumor markers. A tumor marker is a protein molecule that's detectable in either the serum or some other type of body fluid, and it's used as a biochemical indicator that the presence of malignancy. The presence of very small amounts of tumor markers in the body is normal, but we can do labs to see whether or not there's an elevation in the amount of specific tumor markers, and that's an indication that the patient has developed cancer. And if we see an increased level, it's something that should be investigated. For example, an increase in the PSA, which is the prostate-specific antigen, is associated with prostate cancer. So if we see that PSA go up, it means we should do further investigation to figure out whether or not that patient has developed prostate cancer. One of the ones that you hear a lot about is the CEA, which is the carcinoembryonic antigen. And the reason you hear about that quite a bit is it's associated with several different cancers. So if it's elevated, it may be related to a GI type of cancer, breast cancer, bladder cancer, kidney, cervical, and leukemia. So it's kind of a catch-all, so to speak. Okay? We also can watch these tumor markers as we do treatment because we can evaluate the effectiveness of the treatment. We should see those tumor marker levels come down as we do treatment if it's effective. Okay? Moving on. We're pretty close to the end of talking on this collaborate. So we're just kind of wrapping up. Consider in planning for the care of your patient, there are both physical and psychological effects of cancer. We can see some disruption of function that could be caused because of the tumor actually obstructing or laying on different organs or perhaps on different vessels. We can see changes in our hematological functioning, and we'll see the normal functioning of the blood cells actually become affected. Also from that pressure, we can see the development of fistulas. We see impairment of the immune system. Whenever we have the impairment of the immune system, we have such an increased risk for infection as well. We can see depression of the bone marrow. Okay. We can also see hemorrhages, and this is typically through erosion whenever that tumor actually eats through the wall of the blood vessel. Some other physical and psychological effects include anorexia cachexia syndrome. I'm not going to go into that here because I'm going to talk to you quite a bit about that in class, okay? And I talked about earlier that, cancer cells are really good at self-preservation, and one of the things that they can do is they can set up ectopic sites for hormone production. So if they need certain hormones in order to grow, they actually can go ahead and set up a distant site to produce those hormones for them. Just like I also talked about how they can do things like they can actually create new blood vessel structures in order to provide themselves oxygen, or new connective tissues in order to support themselves. Pain. Pain is a major concern with patients with cancer. We can have patients have acute pain or chronic pain. I'm not going to talk about that here either because I'm going to talk to you in length about that in class. We have both physical and psychological stress that the patients with cancer go through. From a psychological standpoint, our emphasis is helping them to maintain their optimal quality of life. It's very important that they get psychological support as well as physical support. We do know through research that actually a positive outlook, that positive support, does actually influence prognosis. And then I've listed for you some very common fears that patients with cancer have. We're moving to the last slide. From a gerontological standpoint, sometimes what happens is that some of the clinical manifestations associated with the cancer are mistaken for age-related changes, and we see this across lots of different disease processes, okay? Um, Patients who are elderly are more vulnerable to the complications of cancer and cancer therapy. Their immune system is already depressed, okay? They may not have very good nutrition already. So their body systems are not functioning at optimum because they're in that sunset stage of life. So whenever they develop cancer and then they have treatments, often those treatments are a lot harder on them and they're more likely to have the side effects from them. We need to be realistic whenever we develop a plan for our patients and look at what the functional status is. Is it really going to be a good outcome for us to undertake this latest treatment? Okay, so the other thing is to think, in other words, whether or not a patient can even tolerate the treatment. If you've got a 92-year-old elderly man who is very debilitated already, is he going to really be able to tolerate that chemotherapy? Or maybe we should try radiation, or maybe we need to talk to them about palliative care. So we need to take into account the quality of life as well as the curative aspect, because sometimes that curative aspect is adding maybe a month or two to life, but we're creating so many other issues where that patient is in pain or they're unable to function in that extra 2 months of life that they may choose to go in a different route. Okay, so that wraps up the first Collaborate for Oncology, and we've covered in here our patho basically, as well as some diagnostics and a little bit of information about overall support for the patient. So wrapping it up,